Ganeshan sir, can I share my slide, please?
You can go to slide share.
Yeah.
Yes.
So I think every time this has to be done. I think for every speaker. Yeah. We'll give a few more minutes because participants are slowly joining in. So.
ನಿಮ್ದು ಮೈಕ್ ಮ್ಯೂಟ್ ಮಾಡ್ಬೇಕು.
Hello everyone. Hello everyone. Hello everyone.
Hello.
Just 2 more minutes and we'll begin. We'll give 2 more minutes and we can make a start.
Vijay?
Yeah. Yes, sir. Welcome, sir.
Welcome.
Welcome, Dr. Jagdish. Welcome, Dr. Jagdish. Yes, sir. Welcome.
Start.
Welcome,
We are
sir.
all ready.
Dr. Jagdish is one of the consultant psychiatrists and director of Abhay Hospital in Bangalore. He is one of the coordinator for this Tele Arogya webinar series. Welcome, you, sir.
Good evening, sir. Dr. Manjula here from Microlabs.
Oh,
Welcome.
thank you, madam. Thank you. Thank you.
Last 1 more minute and we'll begin. Okay. While before I begin, I'll just give some instructions to all the participants. There is a Q&A section where you're free to ask type questions. It will be taken up in the question and answer session in the last. Okay. And there is another thing called chat box where you'll be able to send messages, and you want to make any comments, you can use that. But questions from Q&A will be taken up for discussion. Please do not put your questions in chat box. Put your questions in Q&A. Okay, that's one thing. And we would request everyone else to mute. Myself and Dr. Uma would be unmuted here, and then I think we can start. Okay. Good evening to everyone in India. Good afternoon in UK, and good morning for those who are in US. I welcome you all to this webinar session on health of the elderly in COVID times. Basically, we have 4 panelists. Dr. Uma Madhusudana from Connecticut in US, who is a physician. Then followed by Dr. Ravi Shankar Sargur, who is a consultant immunologist working in Sheffield in UK. Then we have Dr. Mani Krishnan, who is a consultant geriatric psychiatrist in the UK. And in the end, we'll be discussing about the technology part to reach, to ensure the health of the health and well-being of elderly patients at home by Dr. Ipsit Wahia. That will be the last session today. Okay, so each of the panelists will be speaking about 15 to 20 minutes. Some of them have slides, some of them will be discussing directly, and last 40 minutes is dedicated for interactive discussion. So you'll be able to put your questions in Q&A section. So to begin with, we have, since the COVID has begun, we have seen the death rates are slowly increasing in many countries. We have seen it's scary, but what we don't know is who are the people who are at risk. But we, in the newspaper and here and there, or from some experts, we are just hearsay. We are hearing that older adults are at high risk. So we really don't know what is the problem there. So we have an excellent physician, Dr. Uma Madhusudana, who is a physician internist working in Connecticut, USA. and she has done her MBBS from JSS Medical College in Mysore. She is board certified in internal medicine. She has also done MS in allied health and health administration from University of Connecticut. She's currently a frontline physician in a lead team managing COVID-19 patients. She has treated a number of patients already, and many of them are elderly. So we thought, her frontline experience in managing these patients in the wards, would help us understand more about treating patients, especially the elderly in COVID times. So with this introduction, I invite Dr. Uma. Uma, please, can you unmute yourself and share your slides, and you can begin your talk.
Okay, thank you, Dr. Vijay. Let me see. Okay, give me a second. Okay. Sorry, I'm just getting.
Sir, Dr. Vijay, sir, have you stopped sharing, sir, your slides?
Yes, I
Yeah.
have stopped my sharing
Okay,
my
then
slides.
it should be possible then.
Okay, yeah, I think I got it. So good morning, everybody. Good evening and good afternoon. As Dr. Vijay said, I'm Dr. Umarani Madhusudana. I've been working with COVID. I've been in the lead team working with COVID-19 patients at Hartford Healthcare, and I've seen more than 100 of patients, and a majority of them are elderly individuals. So I would like to share my experience and the streamlining and the protocols, what we have done to take care of these elderly individuals, because it can be challenging. So couple of them are like, I'm going to just talk about everybody knows about COVID-19 and what are the main symptoms and findings, what we come across in elderly individuals. What are the risk factors? Why are we saying that, the mortality is higher in elderly individuals, which is true with our experience and the literature, and what are the challenges treating the elderly individuals with COVID infection. And management, even we face some challenges managing these patients too. So COVID-19, as we know, it is a novel virus of the upper respiratory tract. And this was discovered in Wuhan, China in late 2019. And this was designated by WHO as coronavirus disease 2019, hence it's COVID-19. And this has been like a catastrophic pandemic everywhere. So coming to the symptoms and findings of elderly individuals, as I said, majority of the people, I would say till now, I would have seen like more than 60 to 70% of my patients are older age group, like that is like more than 65 years of age. So how do they present? So they usually present from the nursing homes, from home, from the elderly care facility. They do present, they say that they started having loss of appetite, lethargy. There is a change in the normal behavior. Fever, it could be as low as 99, or it could be 100. Dry cough, shortness of breath. And we have seen like a lot of elderly individuals with delirium, with hyperactivity. That has been like, we are seeing a lot of this probably due to COVID-19 encephalopathy. Frequent falls, they are normal, but they start having frequent falls. And sudden onset of weakness, they're not able to get up, walk around, nausea, vomiting, diarrhea. So many, like the medical community, we've been due to the constant mutating virus, we are not able to fathom the symptoms. It can be very severe also. I have seen patients presenting with seizures, elderly individuals with seizures, myocardial infarction, kidney injuries. And also a very interesting case, bowel perforation in an 80-year-old, which was directly related to COVID-19. So it's still like, it's amazing, it's unfortunate that we still are like amazed by the presentation, what these people present with COVID-19 infection. So we have, as a team at Hartford Healthcare, we have been it's an ongoing process of learning and also streamlining the risks and stratification. So this applies to most of them, but also to the elderly individuals. So how do we triage these patients? When do we decide whether they're going to stay home or in the nursing home or in the elder facility, or we're going to admit them into the acute hospital facility or escalate them into an ICU. So demographics is very important. So it again comes back to elderly individuals like above 60 or 65 years. Is a risk factor. Pre-existing pulmonary disease, chronic kidney disease, diabetes, hypertension, cardiovascular disease, a chronic prednisone use, like elderly individuals, a lot of them, may have conditions in which they may require chronic prednisone use. If they're using more than 20 milligrams, then that is a risk. History of transplant, immunosuppression, and I say that, if malignancy is not in remission, and HIV patients, and also we've seen a lot of overweight and obesity, like BMI more than 40. They're we are seeing more and more cases getting these COVID-19 infection. And also we also stratify with the vitals with which they come from. If the respiratory rate is more than 24 breaths per minute, heart rate 125, saturations, and if they're requiring more than 4 liters of oxygen at presentation. And the labs, these are the inflammatory markers which guide us through how to treat these patients. Like we look into the D-dimer, CRP, LDH, ferritin levels, etc. So how do we stratify these patients? So these are for COVID positive patients. So group 1 is like a milder, I would say. Group 2 is moderate. Group 3 will be like a high risk where they'll need to be escalated. So majority of my patients, like where I have been seeing, because I take care of acute patients in the hospital, I'm seeing more and more group 2 and group 3. So group 1 is if they have one demographic factor and one vitals, like respiratory rate, like more than 24, or with the underlying lung disease, then we don't do an escalation of care. We usually tell people to stay home or in the facility and closely monitor, and it's a conservative approach and a supportive care, and we don't usually recommend any specific labs. So group 2 is the risk factor if they have more than one demographics and one vitals. We don't escalate the care, but we will be more vigilant, and we do admit patients to the hospital, and we start supportive care and proning, and we do order COVID tests. And optional, we have like a team of like ID, geriatrics, critical care. We have a team we work on everyday basis how to escalate these people or care for these people, for these individuals. And group 3 is like the most, more severe, where they have like more risk factors with vitals, labs, and we start proning these patients, continuous pulse oximetry. We consider treatment with convalescent plasma. We do the labs, and we consult intensivists and ID to be on board, so that we can give an early, diagnosis, treatment to these people. So then coming to shortly, I would like to discuss with the management. It has been kind of challenging with the elderly individuals, with the management also. There is a lot of theories which has been thrown since this discovering this COVID-19 infection. So, but we have papered it down with all the literatures that supportive care is the main management as of now. So when we say supportive care, like rest, hydration, proning has shown amazing results for us. But in elderly individuals, it becomes very, very challenging for us because they may not want to prone and they may, go back on their back. So it has been challenging with that also. Test therapy, incentive spirometry, that has given amazing results. Also, DVT prophylaxis, as we have been learning more and more cases and seeing with the literature, we have found that it is the disease is more of vasculogenic and thrombotic. So DVT prophylaxis is the key, and we are trying to put all the individuals on high-level anticoagulation or DVT prophylaxis as a part of our protocol. Coming to the medications, so again, as I said, it has been like we have been holding on to the twig. Whatever we get, we want to try it and try to get better with COVID-19 infection. So initially in our hospital with the team, we all, with the literature was what was available, we did use hydroxychloroquine. And if there was any superimposed bacterial infection, we used to use zithromax, doxycycline. However, with the latest literature on this, it shows that, it is like a placebo effect. So we are not using that anymore. Number 2, tocilizumab. We have used this and we did see some good outcomes, and the literature also shows that. But because it's very expensive and also the limited availability, we don't use that much. And the most talked now is remdesivir, which is FDA approved now. So we have to be enrolled in a clinical trial to get this remdesivir. So, and we are, I'm proud to say that we are Hartford Healthcare. We have enrolled in the clinical trial, and we are starting to get more and more supplies of remdesivir, and we are hoping some good results with that. And convalescent plasma therapy. I'm really excited to say that convalescent plasma therapy has been really working very well, especially like I was talking to you guys about like group 2 to 3. So when in that risk category, elderly individuals, like I have given it to a couple of them in the last 2 weeks, and they really are turning around very well. And in Hartford Healthcare, we've almost given like more than 200 plasma transfusion therapies. I just got the numbers from the blood bank yesterday for this webinar. So that has shown a very good thing. And so that is about the management, and it has been like, coming to the challenges. So when I talk about the challenges treating elderly patients with COVID, any patient, any elderly individual, any disease is challenging. However, how is it different for COVID-19 infections? So it comes to that. So many of the patients who come, elderly individuals, especially like above the age of 75, 80, with my experience, they develop this COVID encephalopathy, delirium, confusion, agitation. So what makes it difficult for us with this lethal viral infection is that they're not cooperating with the management guidelines. Like, for example, oxygen, like many of them, they definitely need to be on oxygen, mask or anything, and they don't keep that. They keep removing that. So which makes it and they desaturate, and it's not good. And proning is like very, elderly individuals, they have a very fragile skin. So you want to prone them for like, more than 12 to 16 hours or whatever duration. We have a protocol, we have a team working for that. But it is very difficult for them to be proning, and also pressure ulcers, and then skin, like, very fragile skin. It makes it more difficult for us. And also coming to feeding. So as I said, they have a loss of appetite. Feeding can be very challenging because we need to have like a one-to-one supervision from the caregivers. And with the exposure of this COVID-19 positivity, they don't wear masks and they may cough on the patient, on the caregiver. So the risk of infection to the caregivers or the healthcare providers is really high. There is always like a risk of fall because they're so confused and they try to get up from the bed and they fall. Fear, anxiety, they are in this closed environment because we try to isolate them. We put them on contact and droplet isolation. And the fear, anxiety for the patient is like immense. So that makes it even worse. So that has been challenging. So we closely work with geriatric age group and also the psychiatrists, who help us to manage these patients, giving kind of medical management. Like if their appetite is not very good, we try to give some olanzapine to stimulate, or we give small doses of Haldol. Even that can become challenging because like medically we see if they have a QT prolongation, if there is any contraindication. So it has been challenging taking care of elderly patients with COVID-19 infection. And what happens here, we have seen a lot of outbreaks in the nursing homes. Like the whole 2 or 3 nursing homes are, it's like there is an outbreak, and unfortunately, couple of my colleagues who are taking care also got infected because of that. So what can we do? Because as I said, because the multiple comorbidities what the elderly individuals have, and I would defer it to the rest of the panelists to pitch in with the immune system. So we have been seeing a rapid spread of this infection across older individuals. So source control is one of the important things, like what we are working on. So try to screen everybody who's entering the facility or like a hospital for fever or any new symptoms. Hand hygiene is, social distancing is very important. Early diagnosis, like catching these symptoms with these elderly individuals is very important. If they have any changes, what I mentioned earlier, like if they're kind of lethargic, something different from their routine. So we have to highly suspect COVID in all these patients based on the symptoms, what I explained earlier. Appropriate PPE. PPE is the key for the healthcare workers. We definitely need to protect ourselves in order to protect the patients. Appropriate PPE, I have to stress enough on this. And education and awareness to healthcare workers. What I have seen in these outbreaks is there is not, we need to educate everybody in the nursing home or elderly facility about hand hygiene, about PPEs, or about social distancing, so that is going to help them not spread like collaterally. And family, it's very important to educate the family also, so that about this about this disease, so that the fear, anxiety, and they can guide their loved ones, like because we don't allow any family to go in and out now because of the spread. So they can video call, they can talk to the patient, calm them down, and also education to the patients to wear a mask and not cough, the proper way of coughing. All this really helps. And coming to the prognosis, just to put a highlight on this prognosis, elderly individuals, like good prognosis, what we have seen till now is if they have milder symptoms, I have seen their length of stay is like anywhere between 4 to 5 days, 6 days, and it's and less oxygen requirement. And if they don't have multiple comorbidities, and if they don't have like multi-organ involvement, they have quite a good prognosis, and they get better and they get discharged. And the bad prognosis is at this time of presentation. These elderly individuals, if they're already requiring like a high amount of oxygen, and if their saturations is as low as 80%, tachypnea, then lymphopenia, like kidney failure, abnormal LFTs, multi-organ failure. So these are the ones which is like a very bad prognosis what we have seen so far. Just to like share, I would like to share one case with you, because I recently discharged this patient after an elderly individual after 21 days.
Got 2 more minutes. 2 more minutes.
Okay, yeah. So this is a 77-year-old female who had a history of hypertension, diabetes, who came who had an exposure in the facility, nursing home facility, and she was tested positive. And initially she was asked to quarantine herself in the house, but she started developing worsening shortness of breath, became hypoxic, and she presented to the ED. And we tried to manage her, because early intubation is no more the way to go. We tried to put her on high flow oxygen. Unfortunately, she did not do well. We intubated her, and during that last 2 weeks, we did use tocilizumab, hydroxychloroquine, and Zithromax for her. And she was extubated after 7 days, and then we did proning, supportive care, and after 17 to 18 days, she's back to normal, and we discharged her. So there are some positive lights here. So yeah, and thank you. And I would like to move it on to Dr. Ravi Shankar.
Thanks, Uma, for a crisp presentation. Let's move on to Dr. Ravi Shankar. You need to stop sharing, Uma, and so that I can put on.
Okay.
Okay. Right.
Okay. Welcome, Dr. Ravi. Dr. Ravi Shankar. 1 second. Okay. Dr. Ravi Shankar Sargur is a consultant clinical immunologist from Sheffield, UK. He's done his MBBS from Government Medical College, Ballari, and then he did his PG in medicine in Mysore, MMC. Later, he was a assistant professor at JSS Medical College in Mysore. He's currently the clinical lead in protein reference unit in immunology department in Sheffield Teaching Hospital in UK. He's also a chair for immunology specialty advisory committee, and jointly, I think, with the Royal College of Physicians Training Board, Federation of Royal College of Physicians of UK. He's got COVID experience. He's worked with respiratory inpatients. The title of his talk is Immunological Vulnerability in Elderly and and mortality risk. So we want to hear from Ravi about why there is low immunity in elderly. What are the factors? So over to you, Ravi.
Okay, I'll share the screen in a moment.
One second, I just.
Okay.
Yeah, I've done it.
Right. Thank you for that nice introduction. This is going to be sort of a whiz through a little bit of immunology. And there is a little bit of science, but feel free to ask questions in the QA session. So as Vijay kindly introduced me, my experience with COVID is working on respiratory wards and in HDU. And also, we are doing a couple of studies where we see quite a lot of convalescent people. These are healthcare staff who would have had the infection and been at home, and we are bleeding them for their antibodies when they come back. So we have lots of interesting conversations about how was their experience with COVID. And sadly, there were few deaths. But at the brighter side, I discharged someone who was a 95-year-old back home last week. So there is a balance here. So the plan is we'll think about a very brief overview of immunological response. What happens to the immune system in elderly? Why are they more vulnerable? And think about immune response to COVID specifically and what the test can and can't do. Not going to go into treatment, except for a waypoint where you can look it up, and nothing much about vaccines, but again, a waypoint where you can look it up. So this is going back to your undergraduate stroke postgraduate days. And as you know, there is an innate immune system and an adaptive immune system, and that is the various different parts and also the mediators. So within the innate immune system, you have your macrophages, complement system, etc. And on the here, you have the T cells and the B cells, the natural killer cells and another kind of T cells overlap with each other. When you see an antigen or a new bug, these little things called as antigen presenting cells or dendritic cells are the ones who come in contact with them. They process them and then present into a T cell. So a T cell asks this question to the antigen presenting cell: what is this? Is it dangerous? Is it a virus, a bacteria, etc.? And where is it? So depending on the information it gets, it needs to trigger an appropriate immune response and then enable those T cells or immune reactive cells to go to the right microenvironment, be it your nose, throat, or the lung, etc. And it does it by using something called chemokines and T cell trafficking. So there is a coordinated specific response. So it depends upon the microenvironment at interface. So whether it is the gut, whether it is the skin, whether it's the lungs, then it depends upon the first cells it comes in contact with, the antigen presenting cell, then your pre-existing immune response, whether you grew in a hygienic environment, do you have a Th1 profile or a Th2 profile, and then generation of memory, which is important in preventing it happening again. So when we were in medical school, we knew about CD8 and CD4 cells. Now there are around 96, of which these 4 are the most important. So within CD4, there are subsets. So as you can see on the right-hand side, depending on the kind of the function it is needed, the responses are different. This is important later to understand how this differs in elderly and whether or not it is a good thing or a bad thing. Because in immunology, there is no good and bad things. It's like yin and yang. There is always needs to be a balance. Either way, you would get trouble. So that's my summary slide. So you get an antigen, a macrophage or an antigen presenting cell sees it, presents it to T cell or a B cell, and depending on what is required, the T cell develops an antibody immunity through the B cells if antibody response is required. If it is intracellular organisms like the viruses, you need CD8 response and natural killer response, so you go on the other side. Okay. Now, let's think about what happens in elderly. Like everything else, immune system ages. So, when we get older, we have impaired ability to respond to new antigens, and COVID-19 is a new antigen. And also, as you very well know, elderly get more infections. 2 pre-existing known pathogens. And also, as we get older, we get into a stage of a pro-inflammatory state. And the question then is, how does these things affect the response to SARS-CoV-2? So, if we think about the school for T cells, which is the thymus, which sits behind your sternum, and it involutes. So, this is a picture of showing on the left-hand side at the age of 14 how big the thymic parenchyma is, and it almost becomes gone really by the age of 50. What it means then is the number of T cells which are coming out of the bone marrow can't be schooled to look at new antigens as well as you were able to do when you were a little or in early adulthood. This also has implications for response to vaccines. Now, if you think about other infections, elderly get more influenza, they get more urinary tract infections, they're more prone to pneumonia, they get recurrent tummy bugs. And remember, VZV and EBV, both of which are caused by human herpes viruses, which are very well adapted to living with us. But when your immune system declines, what we call as immune senescence, they can reactivate. And the same thing with EBV. One could reactivate and get lymphomas. This is a summary slide from UpToDate, giving you a summary of various things which happens with your immune system as one grows older. So there is decrease in hematopoietic stem cells, macrophage function goes down, neutrophils and NK cells go down. On the right-hand side, you have reduction in thymus, reduction in the number of naive T cells, and the B cell precursors. So there are lots of things going on, but it is not unusual because as a whole, we are aging. So the T cells change their behavior and become more like an NK cell, which is helpful because it is a key cell in tumor surveillance. So as we get older, our risk of cancer goes on. So your immune system modulates itself to try and pick it up better. But as I was saying, it's a fine balance. If you do too much of an immune response, then you go into a pro-inflammatory state. And one of the complications of any infection is cytokine storm or HLH, etc. Remember, immune system plays a role in inflammation and repair. If there is too much inflammation, then you would get to harm. If there is too little inflammation, you would get harm. So it needs to be a fine balance. And the mechanisms which maintain that fine balance get weaker and weaker, are constrained as we get older. So this is a question which will come up in QA. Can we do anything to keep our immune system working? I haven't used the word consciously to boost the immune system or to get a good immune system. There's nothing like boosting the immune system. One could argue boosting the immune system might actually harm you. So simple things, moderate exercise, sleep well, get the right amount of nutrition. We'll think about vitamin D, zinc, and magnesium, all of which are important, not just for immune system, but for various different pathways in your metabolism. So it makes sense for it to be adequately supplemented. But there is no role for supraphysiological doses of any of this. Now, we talked about immune system, but the complications are really because of the physiological reserve being constrained or homeostenosis. So if you think about other emerging pathogens, look at West Nile virus, which entered US in 1999. It had a case fatality rate of 20%. SARS in 2002, 2003, again, elderly had a fatality rate of 43%. SARS-CoV-2, as you get older, your fatality rate increases. And these stats would change as we get more data. So this is a concept all geriatricians and elderly physicians are very familiar with, that one has significant physiological reserve during our childhood and young adulthood, and that physiological reserve becomes constrained. So we don't have the leeway to fight through infections or get through things while we are compensating for the inflammation and the constraints. And that happens in every organ. So happens in the kidneys, happens in the lungs, and hence they're more prone to getting decompensated. So if we go to mortality, so this is data from the UK Office of National Statistics, and this is all ages. The x-axis shows weeks. So week 1 is the week starting January 3rd, 2020, and a week every week. And this 17th week is the April 24th, so the week just gone. So as you can see, there is a significant increment in the number of people who died this year compared to last year. This is probably the best way of looking at COVID-related mortality as opposed to reported ones, because this would capture the mortality in people who haven't been tested but died in the community or elsewhere. So if you look at age, so less than 1 year, 1 to 14, and 15 to 44, there is no significant increase, although you can see a little bit of a signal there. But if you go to 65 to 74, there's almost 200% increase. The same thing in 75 to 84 and more than 85. This is something which got published 2 days back. They looked at something like 17 million data points in all adult NHS patients and picked up, which we knew that male are more susceptible. And then I want you to look at this one. You may not see it very well, but these are ages. So this is more than 80, this is 70 to 79, and this is 60 to 69. So the hazard ratio is significantly high for people more than 80. Now, we'll switch to tests. To know what tests work, you need to know the structure. So you know that it is a RNA virus and it's a beta coronavirus and it has spikes. And within a spike, there is something called RBD, which is the receptor binding domain. And then there is the nucleocapsid, and then there is the viral RNA. And this is the schematic showing what happens. So the tests would include looking for the viral RNA, which is the PCR. There are some antigen tests looking for spike protein and nucleocapsid in the blood, which are not really good, and they have been shelved in Europe. And then there are the antibody tests. And this is a schematic showing what is the response. So the commonly done tests are the nasopharyngeal swabs. They are very good in the early part of the infection. And they can become falsely negative as we go along. But bronchoalveolar lavages can be positive when the nasopharyngeal swab is negative. That's really important in people who are in HDU and ICU. It is also been isolated in stool, peritoneal fluid, and blood. But the importance of which is debated, whether it is just viral RNA as opposed to live virus. So this is the work from our lab looking at different patients. So each of these numbers are different patients. So 209 and 2010 are negative on a lateral flow test, whereas 403 is a convalescent person who didn't come into hospital. This is day 20. So has both G and M. And then 413 was someone who was in ICU, has a very strong IgG response, and the same thing with 418. On the top, what we are looking at is 3 different proteins, something called the CHO spike, the HEX spike, and the RBD, trying to see whether there is any benefit from looking at different antibodies to different antigens. So hopefully we'll have this test up and running in about 2 weeks, and then we can offer it to locally initially for the NHS and then more widely. Now, this is something to bear in mind. there have been previous beta coronaviruses. And one of the questions one has is whether the antibody is specific to the current coronavirus or a previous one. Because if that is the case, there would be false positives. So there are around 150 tests, of which around 130 are not up to scratch, are essentially useless. So before one would use a test, one need to be confident about their performance characteristics. I will skip that. Essentially, it captures the variability in the antibody response. So different people behave differently.
Ravi,
Yeah.
we got, shall we give 2 more minutes?
Okay.
Yeah, thanks.
This one, look at the right lower hand corner where you can see the antibody response in the elderly is as robust as the others, which is very reassuring. These are the questions for us, which is to think about, is the antibody response protective? If we get an antibody response, how long it is going to be there? If we get a vaccine, whether we need to give a booster or do we need to give them every year? And who should get them? Whether it is elderly, children, healthcare workers, etc. I'm sure we will discuss it during QA. This is an interesting slide looking at population exposure. So these are blood donors in which people have measured antibodies to COVID-19. So Dutch blood donors in February and March, 3.5% were positive, which means they have had the infection, but they didn't know. New York blood donors, there was 7%. New York pregnant women, there's a study showing 15% of them showed antibody responses. Treatments, I'm not going to do anything. This has been already discussed. What I would ask you to look at is this thing. There's something called as the COVID-19 Trials Explorer, put together by this chap called Jesse Raphael, MD. And it's a comprehensive list of all the trials and all the treatments. I would strongly recommend that. And there are 13 trials going on in India. Vaccines, as of 8th of April, there were 115 vaccine candidates. And people are looking at whether one needs different vaccine to different people, elderly, children, pregnant women, and immunocompromised. That's a very rapid overview of immunology of COVID. If someone wants to delve into it, there is a webinar series by BSI, British Society of Immunology, and I would recommend you looking at it. So that was my last slide. Hope I kept to time.
Thanks, Ravi, for taking us through our medical school days, where we learned about B cells and T cells and immune response. I think thank you very much for a crisp and clear message. With this, can you Mr. Ganeshan, shall I say share slide? Yeah. We'll move on to Krish. Dr. Mani Krishnan is a geriatric psychiatrist and a chair-elect of Faculty of Old Age Psychiatry at the Royal College of Psychiatrists. He's working in the Tyne and Ware, is it? Tyne and Ware? Wye Valley, is it? Tyne and, yeah, NHS Trust.
Yes, we are, yeah.
Yeah, University Hospital in North Stockton-on-Tees. He's a geriatric and liaison psychiatrist and senior clinical director of older people services. Delirium is his special interest, and he's also associate dean with Health Education of England. With this, I invite Krish. Thank you for agreeing at a short notice. This has come through from Wendy Byrne, President of Royal College of Psychiatrists. Thank you for stepping in and helping us out in giving us some enlightening information. Over to you, Krish.
Thank you. Thank
Yeah.
you.
Over to you. Yeah.
Yeah. Can you? Yeah. Good morning. Good morning, Vijay, and good morning to the panelists. And thank you for the opportunity. I would like to start just giving a quick overview, as everybody is doing, about COVID and psychological issues of COVID. So what I'm going to talk about, just briefly, the 3Ds in older people mental health, that is delirium and how it is different in COVID, depression, and probably anxiety and dementia. And what are the current problems with elderly, and also what is the future service need and issues with families. So I keep talking about the 3Ds because pre-COVID, this is my bread and butter. This is what I preached, practiced, and worked on with older people with mental health problem. And I have changed the order slightly differently because usually dementia comes first, and then there is depression, and delirium is something as a geriatric psychiatrist we were not actively involved, even though we were constantly involved as a liaison psychiatrist. But from Uma's first presentation, you could see delirium is something that is really, really up in the forefront. So I would like to take a couple of minutes to describe delirium, because delirium is something, whether you're a psychiatrist, physician, pediatrician, anybody need to know about delirium. But however, in older people, the risk of people developing delirium is quite high. And I've just listed various risk factors. Age is clearly a risk factor. From both Ravi's presentation and Uma's, you could see older they are, the higher their risk of developing delirium. And then the frailty that comes in. Underlying cognitive impairment will be a risk factor. And any sensory impairment, visual impairment, hearing impairment, all of them are increased risk factor. And medical comorbidity, and then we talk about COVID as a significant new viral infection would have a higher risk. And polypharmacy is something we all need to be mindful of. This is quite a slightly older present slide by Sharon Inouye from Harvard, but this is an important slide for us to understand why some of our elderly patients are more prone to delirium. So on the right-hand side, you have healthier individual to somebody who is extremely vulnerable. So higher the vulnerability, even a very small insult will cause significant delirium. So if somebody is got polypharmacy, sensory impairment, multimorbidity, and dementia, even a slight change in their sleeping pill could cause delirium. However, when it comes to COVID, COVID is becoming both a vulnerability and a precipitant on both sides. If you think of it, it is quite like a double whammy. So we've got our elderly patients who are already vulnerable, and then you add COVID on top of them, and the trigger itself is a COVID with the cytokine storm. The delirium is a no-brainer. So I do think that delirium is something that's going to be what I call it as a silent giant in this whole pandemic. Uma touched upon it. We would always advocate non-pharmacological management of delirium. However, I think with the COVID situation, with infection to the other staff, patients not accepting mask, oxygen, and various things, clearly there is a need for sedative, even though there is no evidence for any of these medications as a treatment for delirium, but we might have to provide behavior control. And the other point I want to mention specifically for community physicians is delirium could be the only presenting symptom of COVID. And we are getting in our community a lot of examples. I've just recently did a mortality review of 5 patients, our old age psychiatry patients who died with COVID. All 5 of them did not have cough for initial 2 weeks. They did not have breathlessness. They all presented with altered sensorium and confusion. So we are seeing again in care homes and in the patient's own care homes, we are getting some crisis teams are being called for as a new onset anxiety, new onset psychosis, but they all are probably delirium due to COVID. And then coming on to social isolation, again, because it's a brief presentation, I can't do a full justification, but just to quote one particular paper, clearly social disconnectedness, perceived isolation definitely increases depression and anxiety. Here, we have got a real disconnectedness due to shielding and social distancing with specifically our older adults. And it clearly indicates that both isolation increases the risk of depression, and then depression and anxiety symptoms also increases the risk of isolation. Coming on to the next D, that is depression. COVID clearly is a significant risk factor as an underlying risk factor. However, in the current environment, social isolation is a major risk factor. And then other thing we are getting from some of our older adult patients as well as their relatives, and I'm sure even from my own relatives, my parents and in-laws, is that fear, worry is something that's really coming up with our older adults. Fear could be of their own health, about the health of their spouse, health of children, fear of dying without any family member not able to visit or see, like people like me who are living abroad. My parents and in-laws might think that even if they were to be poorly, we may not be able to see them. And then fear of money, lack of money, financial worries, they're all significant risk factors. And then uncertainty. And there was a question from one of the participants saying that, can you give us a clear timeline? Unfortunately, that's one thing. If somebody gets it, they'll probably get a Nobel Prize. So currently, we do not have a timeline for this pandemic. And that is definitely causing anxiety for all of us. And if you think of our older, vulnerable adults, it's going to be higher. And we should not forget patients who already have an underlying depression. And we are seeing in my community team significant deterioration in some of those patients because of fear of COVID, lack of support, and lack of family members are not visiting them, and also supportive care packages that are not being delivered due to the lockdown. The points to consider are compliance. Be mindful that some of the patients who are on antidepressant, the fact that they're not able to go to the pharmacy, they're not getting the prescription. Sometimes this could be a problem of them not taking their medication regularly. And then the other point to think about is access to psychological therapy. The literature says that older adults, there is a reduced uptake of accepting psychological therapy with distancing and lockdown. Providing that one-to-one individual psychological therapy is limited. However, there are emerging evidence of use of tele-technology, and even we have started providing some of the supportive psychotherapy through video consultation. Social prescribing, I'm not sure people outside of UK have the concept. We have got a major push from the NHS on social prescribers attached to general practices, providing various social needs that are being addressed. With the lockdown, they are also being limited. However, we should think about using them as an opportunity. My wife is a GP. She was mentioning that her social prescriber is ringing some of those isolated patients to find out, do they need a loaf of bread? Do they need to ring somebody? Do they need their electricity bill paid or something like that? So the social prescribers could be a good opportunity for us to look at tackling isolation. And there is a higher risk of relapse. At least I could say 3 or 4 of my community patients have relapsed. One of them needing inpatient psychiatric admission, and one of the patients having taken a significant overdose and currently in acute hospital with liver failure. It took a paracetamol overdose. And the other point is neglect, because we are not visiting these older adults. We don't know how the household is, because when we do home visits, we don't not only just look at the patient and talk to them, we look at the environment. Is it clean? Are they wearing clean clothes? Is there food in the fridge? And that kind of neglect assessment is not happening because of the social distancing, which could in turn increase some of those depressive worsening. And I didn't touch heavily on suicide behavior, but that's something, an important point to think about: increased risk of suicide as well as suicidal behavior. Dementia, as of now, there is no clear kind of a direct correlation to COVID and dementia. However, the services have been significantly cut down because of other priorities. Memory clinics in few areas have been closed because staff have been drafted to do other work. But cognitive impairment is not going to change. Dementia is not going to go away. So we need to be mindful that how we can innovatively start providing those assessment services that will be useful. The other important factor with people already having dementia is that due to their memory problem and cognitive impairment, they may not understand COVID. They may not understand their difficulty, and they may not understand social distancing. And there is significant amount of carer distress as well. And worsening of behavioral and psychological symptoms of dementia has been noted in some of the care facilities, and purely because of lack of understanding and the fear factor. Families, there is a lot of problem with families accessing their loved one, accessing their elderly relative, and also them coming to terms with their own health issues and distress and fear. I'm sure people would have seen in various colors and format. Where are we now with regard to COVID? We're still in a bit of a fear zone. We are probably slightly going into some of the learning zone, and then very soon we should be starting to look at the growth zone. As we move on those zones, we should be sharing those knowledge to our families and relatives. We are already starting to talk about recovery plans. I just want to quote Winston Churchill, who talks about perfection is an enemy for progression. It really holds right for COVID. If you were to think of a perfect plan, perfect discharge plan, perfect diagnostic test, again from Uma's and Ravi's talk, you would have said, things are evolving, things are progressing. If you want a perfect solution, we will be waiting for several years. So I don't want to go on to Ipsit's presentation, but technology definitely might have a solution. Video consultation, remote support, and remote working will be useful. However, think of our elderly patients who need a personalized care, in the right care, which is in the right place. The take-home message is, the current pandemic will have a significant impact on our mental health of our older adults. I do think that delirium is a silent giant. We need to be aware, raise the awareness on providing support. COVID could result in epidemic of depression, and we should be prepared for. And then carers and family support is vital, and technology and innovation could help. And I think that's my last slide, and I'll be happy to answer question at the Q&A session. Thank you for your attention. Vijay?
Okay, yeah. Thanks, Krish. Just looking at my next slide. Okay, thanks, Krish. I invite, 1 second. If you say stop sharing, then I can come in. Thanks, Krish. That was a wonderful presentation, and you managed the time as well. Okay. Yes. I welcome Dr. Ipsit Wahia, who is a geriatric psychiatrist and medical director at the Institute for Technology in Psychiatry at McLean Hospital, and he's also an associate professor at Harvard Medical School in US. He's also director of the Technology and Aging Lab. His research focus has been on use of technology in assessment and management of older adults. Currently, he oversees clinical and research program on aging, behavior, and technology, and he has been given an opportunity to be a special editor for COVID-19 for the American Journal of Geriatric Psychiatry, which is a prestigious one. I welcome you. The talk is on the use of technology to manage the health and well-being of these older adults, because we are asking them to stay at home. So how can we use the technology and try and manage their health, either physical health or mental health, and other well-being at home? So over to you, Ipsit. Welcome.
Can I get the screen?
Yeah, I'm going out here once again. Yeah, over to you.
Wonderful. Thank you, everyone, and good evening, good afternoon, and good morning, as the case may be, depending on where you are. My name is Ipsit Vahia, and I'm going to be talking broadly today on the use of technology in the care of older adults in the context of COVID-19. So I'm obligated by my institution to disclose any conflicts of interest, and I will be talking about some companies and brands, but I have no conflicts of interest, and this lists our sources of research support. So this is a huge topic in the context of COVID-19 even. How do we deploy technology most effectively? And if I had to put out one key point at the outset, it would be depends. Technology is not one thing. Older adults are not one thing. And as we've learned from the other speakers so far, the impact of COVID-19 is not one thing. So rather than think about technology in terms of the technology itself, we need to think about the patient, and then think about what the unmet needs are for the patient, and then perhaps brainstorm about what types of technologies can be deployed to help a given patient's needs. So today I'm going to talk briefly about technology and its role in managing COVID-19 itself, the role of technology in managing psychiatric symptoms that may be related not directly to the disease, but to the changes that everyone is coping with the world over. And in that sense, this is unprecedented. And finally, we'll talk about technology that can serve as intervention for older adults or improve their quality of life in general. So let's get to it. Consider this case. A 79-year-old woman in Boston happens to be one of my patients. This woman lives by herself in a senior care facility. She's relatively independent in her functioning, which is to say she has no dementia, but she has a history of COPD, panic disorder, and benzodiazepine dependence. This lady was hospitalized for shortness of breath, and while she was hospitalized, she tested positive for COVID-19. She was sent back to her facility, but now she's restricted completely in her small apartment without the ability to even get out. The challenge we faced here was that she had repeated episodes of shortness of breath, and we were struggling with, is this shortness of breath coming from COVID-19? Is it coming from her COPD, or is it coming from worsening anxiety? Because of her benzodependence, that was a factor as well, in that we could not use benzodiazepines for treatment. So here's the challenge. What technology can clinicians deploy to monitor the health and well-being of a person like this? The other speakers have alluded to how COVID-19 is managed in an acute hospital-based setting, but these are not the majority of the patients. And going forward, as we get better at early screening and diagnosis, we will realize that the vast majority of people that test positive for this virus actually will be living or restricted in the community environment. They will not be needing acute care. As psychiatrists, this is our population. In our case, we plotted out some general principles for how to think of the right technology for managing someone in isolation with COVID-19. It has to, by definition, be a technology that has minimal contact with staff and clinicians. It should require minimum effort from the patients. So something that requires the patient to input a lot of data into an app, for example, may not be a good choice. It also means that the less active effort is needed, the more data you're likely to connect. We know that from research studies on other types of apps, even for things like exercise, that there is a steady decline in how much data you get when it requires to be input actively. Ideally, we want something with continuous monitoring that lets us track the progress of this person in real time. Obviously, we need some sort of technology where data processing and visualization is taken care of. Most clinicians that are listening will agree that if we're given vast spreadsheets with numbers of raw data, for the most part, we're not going to pay attention to it because there is only so much bandwidth that can be spent on processing the data. So we need technologies where the data are analyzed for us. The technology needs to be durable and comfortable. So if it's a sleep sensor that involves putting something in the bed that may poke somebody when they're sleeping, that's probably not going to fly. And ideally, one piece of technology to measure multiple parameters. Now, in my case, I work in Boston, and I have the privilege of being down the street from the Massachusetts Institute of Technology. So we have a number of research collaborations there where we work with people that are developing prototype technologies. We used one such technology. It's a device known as the Emerald, developed at MIT. It's currently prototype, so this is not something that's commercially available, but it does represent the state of the art. Insofar as we can glimpse the future, technologies of this type might represent the future. You can see a picture of the device here. It's basically an innocuous looking white box that sits on the wall and is plugged into the power main. What this device does is it emits radio waves, and think of it as operating like sonar, where depending on how a person disrupts this field of radio waves, the device can continuously track gait, respiration, and sleep. And it requires no charging, which is important because we actually use this even in monitoring patients with dementia. And one issue with things like mobile devices or wearables like Fitbits is that people will often forget to charge it, and then you lose the data that you need. One of the big principles of good work with technology is getting used to the idea that effectively you're providing data-driven care. Another glimpse of the future of psychiatry will be this idea of data-driven care. So this is a little video clip of how this device works. It's completely de-identified, and in this case, the red dot is the patient in question. We made a video clip so you can see how the device captures data. We start out at the time point, and you can see that this person is now moving out from the passageway into the room, moving towards the chair. Now, this is data captured in real time. You can speed up the playback, which we will do now. And when you start looking at playback from basic real-time speed to 25x, you can really get a much quicker picture of this person's movement within their living area. You can see now that this person has left their room. This is not the patient I was discussing. This is a different patient without COVID. But the person comes back, walks to their bed. When they're still, the device can't see them because it does not disrupt the field. But you can see how just this disruption of radio waves is able to track movement and spatial location. The device is sensitive enough that it can actually completely passively map the respiratory rate just by picking up on chest wall movements when this person is relatively still. Now, in the case of our patient with COVID-19, we were able to map out, for example, the difference between a high activity and a low activity day. These are data that we don't otherwise have access to, right? Think about it. To what extent do you know what your patients are doing in their home environment at any given point in time? We are basically dependent just on the data that they share with us. In the case of our patient with COVID-19, we're able to see whether they have high activity or low activity. This in turn allows us to map out whether they may be experiencing anxiety, pacing, or restlessness. We can see what times of the day they're awake, what times of the day they're asleep, if there's been any disruption to the sleep-wake cycle. Once one has access to these data and gets used to watching them in real time, it really helps refine and personalize care. In the case of this patient, we were monitoring their breathing rate, and you can see here that the respiratory rate on average was higher earlier in April. on April 7th, the average breathing rate was 23. Now, 4 days later, as this person continued to recover, you can see the respiratory rate stabilizing as the COVID-induced inflammation in her lungs starts to subside. What's remarkable about this is that we were able to see all of this without anyone needing to actually interact with the patient. I have not been inside the building in over a month, and yet I was able to watch her more closely than I would have if I was paying personal visits to the facility every day. This has an impact on public health too, because it minimizes the need for exposure to both staff and persons. And it sort of gets to the issue of flattening the curve, as we're saying. This work has not been published yet, but it did catch the attention of the Boston Globe. So that was nice. And sometimes not all publications have to be peer reviewed and in the scientific literature to be of meaning, especially when they're very early stage like this is. This approach, however, we were able to do this because we had access to a unique technology. But if you think about how we break down behavior, you can see that it may be possible to even use the gold standard measurement scales. Right now, the neuropsychiatric inventory, which is a 13-item measure of the entire spectrum of psychiatric behavior. You can use various technologies, many of which are commercially available and that I'll talk to actually get real-time data that map out against the standard of psychiatric research measurement, except even a good scale is administered only once a week. And we are now poised where we can get information of the same standard as those scales, except we can get information that is collected in real time. I think we will see that as some of this technology becomes easier to use, less expensive and more available, that all of medicine will get used to providing more data-driven care. We already do this with telemetry in ICUs. We will start to do this in psychiatry as well. I think as more and better data are more easily available, it will change the way we make decisions. There is already evidence on how COVID-19 has been approached using commercial technology. There is, for example, a paper now that talks about how rounds on an inpatient unit are done entirely via video conferencing, where there's a small number of staff on the inpatient unit and the rest of the staff is outside. And they use a platform not unlike the one we are using for this webinar to communicate. And they find that they're able to conduct rounds and provide care just as effectively. At McLean Hospital, where I work, on some of our high-risk units, we have taught patients how to use digital thermometers and digital pulse oximetry, which is so easy. You just give it to them and someone can show them either over video or maintaining a 6-foot distance, how to take their own temperature and their own pulse oximetry. So nursing staff don't have to touch them. They can still talk to people so they're not completely isolated and cut off. But you can use technology to do risk reduction. We even have early evidence that sleep tracking via a phone or a wearable can provide nursing staff and patient care staff data that tell what's happening with the patient, so clinical decisions can be made accordingly. So there's many ways that if we are a little bit creative and we have a survey of technology that you can treat COVID-19 in a relatively acute setting and while the illness is still active. Let's now think about how you can manage other psychiatric symptoms, even in people that don't have COVID-19 but are impacted by it. So consider this case vignette. An 81-year-old male in Mumbai who's a widower lives in a flat all by himself. This person has a history of depression with one past suicide attempt. He happens to have a desktop computer and an Android phone. We know in India that the use of smart technology is expanding faster than almost anywhere in the world, with the exception of China. But the same parameters apply to China too. This person has good physical health and is COVID negative, but there is a risk of depression worsening because of isolation, because of minimal contact with family members, and because this person's routine has been disrupted. The challenge here as a clinician is what technology-based approaches can be deployed by the family and the psychiatrist to make sure that this person's depression is not getting worse and they're not at risk for suicide. Here's a question, and I will answer this. In live audiences, I ask the audience to raise their hands. So this is part of our learning when we can't do in-person conferences for a little while. Turns out there's a number of ways to detect mood just from a smartphone. Every single use is supported by a peer-reviewed publication. So this is not conjecture. This is something that has been studied and demonstrated. That how many times a screen use goes on and off has been associated with depression-related markers. Same with a fingerprint scanner going on and off. With the idea that if someone is engaging with their phone less, that might be a measure of apathy or lower activity and lower social connectivity. Does not apply to COVID-19 and social isolation, but GPS location can tell you when someone is at work, when they're at home, when they're in a restaurant, etc. It's a marker of anhedonia. Same thing with total app use. Which apps are being used and when and how can lead to being able to track depression and mood. We now know that typing patterns may be a biomarker, and this is being studied and funded at the highest levels of the NIH in the US. Text messaging, of course, both email and number of emails or number of messages sent, whom they're sent to, how often they're sent. In some ways, this is a way to actually see what used to be self-report, which is how much is a person talking to their near and dear ones. I'll talk a little bit more about motion sensing through actigraphy. We know that you can capture facial expressions that artificial intelligence can process to actually pick up very subtle mood changes. Changes in voice. We were interested in our lab on whether clinicians are actually starting to use this as part of regular care. This was a study we did last year, and we found that in a survey of McLean Hospital, that 86% of our clinicians actually look at patients' text messages or emails as part of psychotherapy. We're not doing this routinely yet, but the future may hold a case for psychiatrists to start getting used to this, that we start thinking of text messages and emails as part of the conversation that we have with our patients. Right now, as the entire field is moving towards telecare because we can't see patients in person, we are finding that access to this digital information makes up for a lot of the loss of data and context that we might have otherwise. So I think for the clinicians listening in, this is something to think about. What information might be available on someone's WhatsApp or text messages or emails that you could use to get a more real world sense of how this person is doing, so it reduces your reliance on self-report. Our group also just published an important paper in the Harvard Review of Psychiatry, where we make the case that what technology is allowing us to do is break down the 9 DSM and ICD criteria for depression into their components, and that we can actually now study each of these individually. As Dr. Mani mentioned, sometimes these symptoms of COVID, but also other psychiatric manifestations without COVID, they look different in older adults. In COVID, we may see delirium before we see any cough. Similarly, in older adults with depression, you may just see changes in sleep and appetite. This is why the epidemiological studies of mood in the elderly have always had their limitations, because depression looks fundamentally different in older adults. Technology is a way to bypass that. It's a way for us to potentially more easily and more specifically diagnose and map the progress of depression. Many of these technologies are things we can find in a typical smartphone or a wearable device. So it may be that the very notion of ICD and DSM criteria are going to need to be questioned and revised and made specific for various demographics, be it based on age or based on psychopathology. We will see, but this is the work that we're doing right now. Here's a much simpler case example. You can use actigraphy, and this can be a typical Fitbit, now widely available all over the world. And you can use this actigraphy to map sleep, you can map physical activity, you can map inert time, and it can be diagnostic within clinical context. We published a paper in the American Journal of Psychiatry in 2016, and this is an actual screenshot of this patient's smartphone, where in this case, by looking at his Fitbit data, we found that this person was walking an average of only 839 steps a day. Now, this was one of my patients who had chosen not to tell me that he was not getting out of bed because he wanted to maintain the impression he conveyed. It was not until I looked at his smartphone data that I asked him, why are you walking only 830 steps a day? And it came out largely from his wife, not from him, that he was not getting out of bed. And in fact, the highest activity he had during the week was when he got out to come and see me. Based on these data, we changed the treatment plan. We noted response. And what was cool about this was as he got better, his physical activity went up and he was actually able to see it. Now, pre-2007, this was simply not possible. But letting patients actually see their own data has been shown to be a positive reinforcement in and of itself. So I encourage everyone listening today to start thinking along these lines. Find ways to let patients see their own data, and it's likely they will adhere to treatments better and they will be more invested in their own care and management. It becomes more of a partnership than paternalistic. Dr. Mani mentioned telecare as well. There is now early evidence. So these are papers that came just, and I apologize for the little font size discrepancy here. But even in the 2 months that we've been dealing with COVID-19, there is early evidence that it's being used. Telecare is being used for psychopharmacology. So people managing their patients' medications using only telecare. There is now early reports of CBT being successfully used with telecare. There is a model described for ketamine infusions and ECT, where telecare has a component. And then CBTI, which is a specific form of CBT with for insomnia that you can download free apps. These are creative ways of getting people that have access to technology to adapt it and use it so that you can administer the usual components of psychiatric care, but in a way that allows people to get their care and make adjustments either with no human contact or minimal human contact. We will find by the time this pandemic and the isolation measures subside that there is a lot of what we currently require, brick and mortar locations and in-person contact, that you can replicate the processes at least partially. We cannot, I don't think we will fully replace it. But to a great extent, you can do what you're doing now without needing people to come by or without needing people to talk to a large number of people. The future is going to be more remote. The future is going to have minimal human contact, at least until we have a vaccine. But technology is making this possible in a way that might not have been otherwise. I will go so far as to say if this had happened to us in 2002, I don't know what we would have done. And lastly, just a little touch on technology and intervention in psychiatric care and how you can enhance quality of life. So here's another case vignette. A 72-year-old lady in Bangalore with mild cognitive impairment. She lives with family. She does not own her own technology, but she may be able to learn. And say she asks her family to teach her technology so she can be less dependent on them after the pandemic subsides. In other words, this is someone that is thinking that because everyone is at home now and they're not out doing work, and that everyone has technology, maybe she can use this time with her family to actually develop skills on her own. This ties to the idea of lifelong learning, which we know protects people from dementia advancing. So the challenge, how can someone that is older be taught technology most effectively? The simple answer, and why I framed that case vignette, is that we know that the fastest predictor of an older adult learning technology is if there is a younger person in the household that is able to teach them. You can have classes, you can have instruction manuals, but there is no substitute for a younger person, preferably family, that can actually spend the time teaching an older adult how to use technology. In our clinics and in our lab, we really deploy this principle. It means you have to spend more time and effort early on in bringing the older adult on board. But if you do that, It means not only will they learn the technology, but they're likelier to use the technology more closely, more effectively, and even better than younger adults. So it's not that old adults don't use technology. It's that they will only use it if it has a tangible impact on their life and well-being. And they will only use it if they are trained properly. But once they are, they use it more closely and more diligently than a younger adult might. They also have diligent use, device use preferences. So most people have a desktop computer now, but for older adults, it may be too bulky and too importable. So if they need to get out and walk to a different room or walk upstairs, that gets in the way. Laptops help, but laptops are complicated and they are heavy. This is the Microsoft portal now. If you have challenges with vision, you may not even be able to see and understand what's out there. Cell phones are portable, but the screen is too small. We know that older adults may have fine motor restrictions, so typing can be a challenge. The right technology seems to be tablet devices because they are portable, but they have bigger screens and you can change the size of the keyboard. So keeping the type of technology in mind matters. We know from different studies that it's actually most effective if they use the same technology as their grandchildren and that their grandchildren teach them how to use them. The best predictor of getting someone online when they're older is thinking through these things at the very beginning. Getting it just right.
For 2 more minutes, I'd say.
Sure. There was a study last year, this is one of my favorite papers, that actually looked at, for older adults, what platform of communication technology was most effective. And they found that in a straight comparison between Skype, email, social media, and text messaging, that only video chatting was associated with an improvement in mood 2 years downstream. And this makes sense, right? Because video chatting is the technology that most closely approximates human connection. So we think of using all of these different ways of staying connected, but all connectivity is not the same. In the end, the connectivity that is most real-time, that is most visual, and the one that most replicates in-person connection is the best. So if you have family members or patients, talking to them through WhatsApp or Facebook or emailing them, it's better than nothing, but it's not as effective as video technology. In our lab, we've actually been using technology even to enhance treatment as usual. So we developed a group-based intervention where we combined photography, mindfulness, and meditation. And we taught our patients how to use images, either pictures they took themselves or pictures that they downloaded. And we taught them how to edit these pictures to express what was on their mind. So this is an example of an elevator shaft in our hospital that someone took a picture of, but used it to describe how depression felt like being stuck at the bottom of a pit and looking up and wondering if they would ever find the light. It led to a better verbalization of internal mood states. In a culture like India, where people don't talk about mood as much, this may be a way to try and get people to express their emotions, especially older adults. This may be a few years away, but we're actually looking at virtual reality and how virtual reality can enable reminiscence therapy and mindfulness. And reminiscence therapy is just a way to get people to talk about their life histories and find meaning in their own narratives. For example, what we do is we use virtual reality headsets and place people in VR outside the street where they grew up on. And we've been amazed by how much it gets them to talk about their childhoods. And you get a different picture of what this person or who they used to be. And I think as VR becomes more common and kind of seeps from gaming into the real world, this will start to gain more traction. In our clinic, over the past 2 weeks, we've deployed a geriatrics technology education team. So because we were forced to do all of our outpatient visits for several thousand patients over remote care overnight, what we've started to do is find out when someone makes an appointment whether they have technology. And if they do, but they don't know how to use Zoom, we have our research assistants actually call this person up and do a mock visit. And what that's led to is people that were not able to do video care are now able to do so. In the 15 referrals we've had so far, 13 have led to successful televisits. So that's an 86% success rate. It's effort intensive, but it seems to work. And we're going to be tracking this and hopefully publish it soon. But there's a lesson here that can be applied across all contexts, that if you can teach them, it helps. One final thing, there is now a scale for measuring fear of COVID-19. I'll leave this slide here for a little while, but it's free and it's easily available. It's called the FCV19S. It's a way for us to more objectively measure how much people are afraid of COVID-19. And I think when you can quantify it, you can track what the impact on their life might be. We also know that people might report more honestly on a scale than they would with family members because of pride, because of stigma, etc. So this is something to watch. I'll stop here. Thank you.
Yeah. Thank you, Ipsit, for a very informative talk. Let's move on without wasting time because we are running short of time. Let's move on to a question and answer session. So you're all okay with taking questions? Is that okay?
Yep.
Yeah, okay. So we can unmute. So there's a question, I don't know, we'll find out who is the best person to answer. From Naresh Vadlamani, he practices in Hyderabad. Are the experts in COVID or pandemic giving the right information to the world about the seriousness or extent of the problem and a prognostic picture for the next 6 months or the next 1 year? This information will help the governments to budget their health costs, prepare for the health infrastructure, and thereby get a control over the morbidity and mortality in the next 1 year. So I think Uma and yep.
Oh, okay. So it is, the way it is going, I feel we definitely need some time to see whether it's going to be better in the next 6 months and or not. It is definitely going to be a challenge at this point. We can't, because this is something new. We are seeing like new presentations, new symptoms, and there's like billions of dollars being invested to prepare, vaccines, as my other panelists spoke. So I'm not sure about that, and probably it's too early for me to comment on that as of now.
Okay, right. Are the mortality rates high with the patients you're seeing in elderly? You also have a similar experience?
Yes, definitely. It is
and
like
roughly, if you're treated about, let's say, 10 patients, then how many elderly patients you had, and how many of them actually died?
I would say at least, if in my experience, in in the past 6 to 7 weeks, I would say, apart from my own patients, overall, it's around like 5 to 8%. Anything between that, 5 to 10%.
Yeah. How many patients on a given in a given ward are actually are older adults? Like out of 10 people, how many are older adults?
70 to 80%.
So 8 patients are.
Yeah, 70 to 80% of my patients are like above age of 65, but it's changing now. We are getting like more younger patients, between 40 to 60 also.
Okay.
And I've seen as young as 26 years old.
Yeah, from the one of the figures that Ravi mentioned, it was about 15%. The fatality rate in elderly was 15%. Would you agree with that? You think 15% comes to around, I think.
Yeah, I would, because a lot of them we don't see in the hospital, but in the facility, in the nursing home facility. So they either decide to become like a hospice, like a comfort measures only, and they they expire with the COVID. So I don't have those information, but I would say yes.
Okay, in the ward, of the number of deaths, how many are elderly? How many are older adults?
I don't
if
have
there are
the
10
exact...
deaths. If there are 10 deaths, how many would be older adults, roughly?
I would say last 2 weeks, in fact, Vijay, I had like 4 to 5 deaths who are all like, you know, in the age of like 80s and 90s.
Okay, in the last 2 weeks.
Yes, 4 to 5 deaths. Yes.
Right. Okay. Okay. Yeah.
On my service.
Yeah, that's useful.
Yeah.
Okay. Right. And this is a question for Krish as well as Uma. How frequent is it's from Shrikala. Professor Shrikala Bharat is a psychiatrist. She's also was practicing old age psychiatry before. How frequent is a delirium, and what is used to control the hyperactivity?
If I want to start with it, I think we say normally pre-COVID 20% in a general ward, and then in ICU 80% is delirium. But now the statistics are all gone differently. They would say 2/3 to half of the patients, older adults who will have delirium, or even more, and some people quote up to 60 to 70% would have delirium. So the commonality of delirium occurring is quite high. Coming back to hyperactivity, again, Uma mentioned on a couple of occasions, even though we like to do non-pharmacological, but at this time we are curtailed due to infection, there is no right fix. If you think of respiratory depression, benzos are going to have a problem. You know, if already their SATs are low. However, you know, anecdotally, a couple of my patients, not in ICU, but in a geriatric medical ward, the haloperidol did not work for them, but a small dose of lorazepam, 0.5 milligram twice a day, actually settled them. But they were cautious that they're making sure that they could look at reversal. And then some of the antipsychotics, the other difficulty, I think Uma mentioned, there's QT prolongation. So some of these patients are antipsychotic naive. So it is very tricky whether we want to load them with antipsychotic. But our answer is, if you need to settle them to treat the COVID, you have to use the appropriate methods. It could be from anything from non-pharmacology to higher dose of sedation. But be mindful not to put it as an order, but to be reviewed.
Okay, this is for
Can I ask a question? Can I ask a question?
Yeah, please go ahead.
So, I mean, this is very interesting because what is your thought like about Dr. Krishnan, about like, if it is really impossible because of the isolation and the risk of the caregiver getting you know, this infection more, what are your thoughts? I know that it's like it sounds not good, but restraints or soma beds, you know, like, you know, enclosure beds. What do you think about it with COVID patients?
Yeah, for the sake of learning, I'll rephrase this question. I think, how different is it treating delirium, you know, compared to the pre-COVID era? So, how different is it?
So I incidentally, I had this discussion with the patient and the family on Thursday. It took me more, normally it takes 10 minutes, it took me 45 minutes. So I explained exactly what Uma just now mentioned. I explained about chemical restraint. So instead of physically restraining them, tying them up or putting in an enclosure, we are actually restraining with medication. But we are physically also restraining some of those very aggressive patients in psychiatric intensive care, both in adult and older adult and some of the learning disability facilities. So it's not that we have not practiced it, but when it comes to delirium, the other difficulty we might be having is respiratory depression, physical problem, and also we are not able to monitor them physically. Again, some of the IPSIT technology will come to our use. Like, you know, I've just now started using some of the remote ECG devices, you know, which is like a small device that you can touch and put it on your knee to get an ECG recording, compared to putting all the wires into the chest. So it is about risk benefit, and also, are we comfortable to monitor side effect and monitor the harm? So coming back to the question, if the chemical restraining is going to cause more harm than good, we shouldn't be using it. And I think when the peak was there, we had no choice. But now, as the peak is receding, we need to have some ethical consideration. So in fact, in our trust, we have set up an ethical committee, almost like, it's not like going to a paper and things. very quickly, couple of peers giving you advice like what we are doing just now. So I think that's my view. Risk benefit, my mantra right now is what is the need and what is the risk. So if the need is high and the risk is low, go ahead. The need is low, risk is high, don't do it. If it's 50-50, make a decision.
So basically, so you're practicing in the sense in the wards, practicing physical restraint also, which wasn't the case before.
Yeah.
Is that what you're saying, Krish?
We do.
Yeah. Okay. Ipsit, you want to say something?
I'll add a couple of points. Dr. Krishnan referred to Sharon Inuye's work. She, again, I have the privilege of working across the street from her, and we reached out to her group because we were seeing this on our own inpatient unit. So we collaborate with them, and her word carries weight because she might be the world's final authority on delirium at the moment. But their recommendations were in line with what Dr. Krish said, that the usual principles of managing delirium apply. I think she alluded to the fact that mood stabilizing medications may be more effective because there seems to be a dysregulation of mood and anxiety rather than the primary agitation that we see with dementia or schizophrenia. And we've been deploying that. So you know, just in terms of what medications we use, gabapentin when someone will take it orally because it's the safest of the medications and the least impactful on the system. We have used both divalproex and lithium, which have been shown, especially at low doses, to work in agitation and dementia, starting lithium as low as 150 milligrams. It's tricky though, because lithium has the same problems that ibuprofen does in that it can impact the kidney. So it has to be done very, very delicately. Another one, and this medication may not be available anywhere, but we've been using dronabinol, which is the synthetic cannabinoid. And that is actually proving, at least based on small anecdotal evidence, unpublished so far, that if you can target agitation and delirium through the, in the context of COVID agitation, if you can target that through the endocannabinoid receptor system, that seems to at least anecdotally be helping. I don't endorse it. There is no published data on it. But there are studies now looking at this or CBD for agitation and dementia that we have tried to use in COVID-induced delirium with some effect. I think the point is that untreated agitation is in some ways more dangerous than any side effect from the medication. So I think achieving that level of sedation is important, especially because in the context of systemic inflammation, that could trigger a stroke.
And just to add,
very much evolving science, it changes every week.
Just to add to your list, Ipsit, I have used pregabalin for severe anxiety, and anxiety seemed to be, and it is evidence-based for pregabalin for anxiety. So what, again, as Ipsit alluded to, the delirium we see in COVID responds and behaves very differently to what the delirium we saw pre-COVID. So, and that's why we don't want to use the treatment as usual as an immediate go-to, which we did a few weeks ago, but now we have the time to start thinking slightly differently.
Also for the audience, I'll share a resource. So the American Journal of Geriatric Psychiatry, we issued a global call for papers, and the response has been extraordinary. So these are all peer reviewed and they go through an expedited editorial process. So I think it represents a level of evidence higher than the newspaper or the news. It's all open access. It's all free. If you go to ajgponline.com, there's a COVID-19 section. There's new papers being put up every day. But the journal and Elsevier publishers, they helped us build a system that would let us generate rapid evidence for immediate dissemination worldwide. And I encourage people to look at it because even the case reports there, we found them extremely useful, even in just deciding what inpatient policy needs to look like. So check that out.
Yeah. Okay, I'll take another question. This is for Ravi. While I'm discussing this, could the other panelists try and answer the questions that has been put forward, because we're running short of time. They can type the answers to the audience, because we need to take care of our audience. Okay, Ravi, this is for you. Thanks for your informative talk. This is from Dr. Divakar. You mentioned that immune boosting measures may not be helpful, especially in elderly. What's your take on Indian Ayush recommendations on immune boosters? if you had a chance to look at the Ayush recommendations. Then,
Right. I'm smiling because I just read that and I went and looked at the Ayush recommendations. Makes an interesting read. There are two components to it. Majority of it is about healthy living, which is perfectly fine. The second bit, which is about using spices like haldi, jeera, garlic, etc. In vitro studies, they do have some effects on immune cells like macrophages, etc. I don't think one would achieve the same concentrations in vivo in the cellular microenvironment by the amounts of spices we use in the cooking. It would have to be supranormal, and you would probably get side effects from it. So, perfectly reasonable, makes things tasty, but I don't know whether that would provide one with additional immune boosting benefits. Remember, I said boosting is a word which I don't like. If you boost your immune system, you can actually cause harm. The specific ones, Ayurvedic immunity promoting measures, talks about Chyawanprash and one more product. I don't know what's in Chyawanprash and whether there is in vitro experiments looking at how it changes T cell signaling, B cell signaling, etc. So one knows that all of us have tasted Chyawanprash, tastes nice, it doesn't cause harm, and if it provides with reassurance, that's fine. But that's the best I can say.
okay, Ravi, this is $1 million question. In general, this question is, how far are we with regard to vaccine trials and
right.
When can we expect? It's in the newspaper we see every day claiming and this and that, and I mean already there are reports in the newspaper that vaccine has been it's been produced or manufactured. Without trial, how can they manufacture? I don't know. So can you throw some light on
right.
that?
So I put up one slide where there were 115 or so candidates. There are 4 trials which have been started, and one in Oxford most recently. And probably by early next month, a proportion of healthcare workers in the UK, because they've asked for volunteers to have this done. The rate at which we develop these vaccines has been phenomenal. It's the first time in history, within 4 months after a new pathogen, one can get to this chain. And AI and machine learning have helped enormously in selecting the targets, etc. So
And
when it could be available depends on how they behave. The colleagues in Ohio, Maryland have got a coronavirus, a SARS-CoV-1 vaccine. The sequence homology between that spike protein and the CoV-2 spike protein is around 60%. So they are going ahead with a trial to see whether there is any benefit. The newer ones will take anywhere between 12 to 18 months. That's the minimum timeline to get there. What we are all concerned about is safety. Because when we developed a vaccine for Ebola virus, there was a problem with immune enhancement. People who had the vaccine actually had more severe disease, which would be really sad if it happens. And also, one needs to be certain that it is efficacious. It's not just about developing antibodies, it needs to be protected. So a reasonable timeline would be 12 to 18 months.
Okay, once you give a vaccine trial, would you actually infect them with some low immune pathogen to test whether they're going to develop the disease or not? How does it work?
So what one would do in phase 1 and phase 2, even during development, is what we call as neutralization studies. So if we give a vaccine, or if I have a vaccine and I develop an immune response, the simplest correlate would be my antibody titers. If I take those antibodies and co-incubate with a live virus or something called as a pseudovirus, the virus should not replicate. on a live culture. So that would be a very good correlate to say I have neutralizing antibodies. So that would be part of the vaccine development strategy in different models to see whether the response is protective. Only then it can go on to phase 1.
Okay. This is the next question from Dr. Vihang Goya. Is it possible to set up a team of psychiatrists in India to collect formatted data and get IPSIT's lab to interpret it? I think I need to discuss this with a group of psychiatrists here, and then I think we can discuss with Dr. Vihang Goya himself.
All I will say is send me the data and we'll see.
Yeah, fantastic. Okay, this is a question from Dr. Bhavesh Lakdawala, and he's asking, have you started using technology you mentioned? This is for IPSIT. Have you started using the technology you mentioned in COVID-19 specifically? And if so, if yes, how is the response?
We have. We've started. So I mentioned several technologies, and I'm not sure which one Dr. Lakdawala was alluding to. But we're using it at several levels. The Emerald technology from MIT, we're actively deploying it in 5 COVID positive patients. These are not in the hospital; they're at a senior care facility. So the benefits, it's remarkable. It lets me actually, watch people on my dashboard and see what they've been doing on a continuous basis every day. It's a more close look at how they're doing than I would if I was even visiting them in person every day. And I haven't been within 15 miles of the building. So, to just wrap your head around what exactly that represents in terms of technology advancement is extraordinary. On the other hand, this is not commercial technology. It's not an approach that is even easily scalable where we are, because it's prototype research. So we are only able to do this in a small group of subjects in a specific location. So the capability is there, but a lot needs to happen before this becomes the mainstream. So it's the very bleeding edge of how we're doing it. Now, within McLean Hospital and with some of our regular outpatients, we're using a combination of wearables. We really like using wearable devices like the Fitbit because in principle, it does the same thing. It gives you some continuous data. It's not research grade. I think there's a lot of difference between devices. So you can't compare between individuals, but within the same individual, you can see how things change from time to time. It's possible at this point to measure temperature, pulse, respiratory rate, and blood oxygen saturation using remote passive technology. Blood pressure is the holy grail. We can't do that yet.
What about diabetes? Diabetes, asthma, monitoring of asthma.
So asthma, you can, respiratory rate can reflect changes in asthma. Diabetes is, that's widely available finger stick monitoring devices. Among the labs, it's not really possible to get electrolyte levels, but you can get metabolites remotely. You can get ammonia through breathalyzers, and you can get glucose levels through finger sticks. We don't do that as much, but several of our colleagues at other hospitals in our system do, including Massachusetts General and Brigham and Women's. So at least here, and I think there will be a trickle-down effect, we're getting more and more adept at the idea that you can get a lot of these data without anyone having to leave their house, as long as you can send the technology to them. Cost is a factor. Someone asked a question about data privacy. That's a different factor, and there are, those could be separate to our webinars in and of themselves. So I won't go into those in great detail. I typed out an answer to one of them with some general points.
Fantastic, thank you. Just quickly, couple of more questions, I think. So Ravi, what about BCG? And the next question to you only is, what about, are we waiting for herd immunity? Is it what the final answer is?
So BCG, you need to look at it 2 ways. One, BCG will not provide a specific protection to COVID-19 or to anything else because vaccine responses and protection is specific. What BCG does, though, is it increases what we call a Th1 immune response, which primes the T cells to switch to what we call as the Th1 phenotype, so CD4 T cells, and appropriate cytokine response, IL-12, etc. So that provides one with a background of an immune response, which is more feasible or amenable to develop an appropriate immune response as opposed to a Th1 response. People have also looked at linking a BCG or inactivated bugs, including adenovirus and BCG, to other vaccines to boost their immune system so that the innate microenvironment is facilitating an immune response. So as an adjuvant. So in that way, it would be helpful. There were 2 studies looking at the signal of BCG as a policy. And although the initial study showed that there is some favorable response, the subsequent meta-analysis and review hasn't shown that. So it's really interesting, but BCG acts as a vaccine adjuvant. So that's the first one. The second one was about herd immunity. I didn't put up that slide for lack of time. Herd immunity depends upon R naught, which is the number of people you would infect. So higher your R naught, you would need to have a higher herd immunity. So if you take measles, for example, your R naught is something like 7 to 8 or 9. In that scenario, you need to vaccinate around 95% of your population to get a population immunity to around more than 90% for you to protect. Whereas with COVID-19, if one assumes the R naught to be around 2 to 3, around 60% of your population needs to be herd immune. Currently, in the UK, the quoted R naught is between 0.5 to 0.9. That's essentially because everybody is isolating. And if one relaxes the isolation and the lockdown, the R naught has a potential to increase. And that's the worry at multiple levels, that it might bounce back. The US, the colleagues in Newark, Florian Kramer's lab, and I forget the epidemiologist's name, did an interesting assumption and thought experiment to say, okay, in the pregnancy study they did in Newark, 15% of the pregnant women had exposure. And if so, can one assume 15% of the New Yorkers had exposure? Is pregnant women a good representation of the population in general? And if so, can one relax the lockdown measures to working age group? So up to 45 or up to 50, because the risk of morbidity and mortality increases. So that comes back to what you were asking earlier in our conversations about cocooning. Would you continue to cocoon people in elderly, but can the working age population can come back to work and contribute? Because 15% is quite reasonable, but if we get to 40 to 50%, we will start to get to a level of herd immunity which is protective, while still isolating the more vulnerable.
Okay. I think I can take one last question. This is in general. Are HCQs suggested or recommended for elderly? Who wants to answer?
Okay, so
as a preventive measure.
As a preventive measure, okay. I think that's a nuanced one, because there were a couple of publications from yesterday and day before which said, with a headline, finally death knell into HCQs for treatment. So a meta-analysis has showed that there is no real benefit or there is no real signal for treatment. Prophylaxis is an interesting one. One, there is no data. But if you ask the question about, especially in elderly, there are studies in VZV and CMV reactivation, where using an anti-inflammatory agent before an experimental challenge had shown some benefit in preventing the severity of infection. Whether that would hold good for COVID-19, we don't know. And then Uma can come in.
Uma, have you seen in your wards anyone who had tried HCQ prophylaxis. A patient who has already been on HCQ prophylaxis but still developed COVID infection and complications.
Yes, I had a patient who had rheumatoid arthritis, and that patient was on, hydroxychloroquine for a long time, and she did develop COVID-19 infection.
Okay. One last comment from everyone in the reverse order of your talk. What is your advice to the elderly? What do you want the doctors and psychiatrists to advise to their elderly patients? In 1 or 2 sentences. In the reverse order. In the reverse order. Yeah. Ipsit first.
Oh.
Want me to start?
Yeah.
Okay.
Yeah.
Technology is out there. We haven't thought of it necessarily in the context of using it in a day-to-day basis, but get used to thinking differently and think about how you might use something to break the mold of care as usual. The world we knew is probably not coming back, at least not the way it used to look. But we have our technologies. We need to get better at deploying them and becoming more data-driven in how we do care.
Krish.
I think I talked about 3D. Be mindful of the 4th D, that's the dignity. I think our elderly patients, because of all this going on, everything is getting overwhelmed. And I'm seeing and hearing some of the literature coming on patients being stereotyped. And in fact, one of my 83-year-old patient fought with a geriatrician last week saying that I'm 83, but I run marathon. So treat me as an adult. Don't treat me as an older adult. So that's a clear message. Clearly, we need to be looking at, we can do all those stratification, but they are still human with a lot of potential intergenerational kind of things they can do. So give them dignity and the rest others can cover.
Yeah, Ravi?
Right. I put one slide, didn't I, about asking the 3 key things for your immune system is sleep, healthy diet, make sure your vitamins and micronutrients are adequate, then moderate exercise. And I'll add the 4th thing, like Mani just did, is mood. There is a lot of data to show that your mood influences the way your immune system functions. There is psychoneuroimmunology as the new field itself. So try and make sure that your mood is at an optimal level, whatever you want to do, whether it's beliefs, faith, religion, family, friends, as Ipsit was saying about video communication. Those 4 things, sleep, exercise, diet, and mood is the main things to get through this.
Uma, final comments?
Yeah, pretty much everybody covered the key points. So from my side, I would say that with COVID-19 infection, treat the older individuals and the non-older individuals the same way. Social distancing is the key for this, and hygiene is the key. And family and emotional support, like others said, that is also very important for the elderly individuals. That's what I would say.
Okay, going by, asking everyone to say final comments has already summarized. So there isn't much for me to summarize. I think we already run out of time. I must thank everyone, Ipsit, Krish, Ravi, Uma, Mr. Ganeshan, who are hosting and supporting us, Dr. Manjula, and my colleagues, Dr. Mahesh and Dr. Jagdish, for this wonderful and informative, what I believe is wonderful and informative, learning experience for elderly patients. And I must thank all the audience who have been patiently listening to us and asking questions and try to be interactive. We owe a sincere thanks to you all, and thank you very much for everyone, and have a nice day.
Thank you.
Thank you, sir, moderating it so well, Dr.
thank
Vijay.
you.
It was
Thank you.
Thank you
I
very
think
much.
it was a very enjoyable,
Thank you, everyone.
very knowledgeable.
Very knowledgeable, extremely good sessions. I must thank each one of you. Extremely good. Maybe Mr. Ganeshan may, I think, put it on YouTube, like many gets benefited with the
Yes.
consent of all this. Lot of information, sir. We got it. That too, first-hand information from the frontline warriors. What do you call that? They see patients every day basis.
I don't
Thank
know
you so
whether
much.
few people know, but Uma had this, people coming in.
Uh-huh.
What is it?
Yeah,
What
it
do
was,
you call that? What do you call that?
it was
Drive-through
an
honor.
unsung,
Drive-through honor.
yeah,
Drive-through honor.
honor. Yeah.
Yeah.
It was for all the frontline workers, and I was fortunate to be one of them.
Okay, great.
Yeah,
That's
excellent.
great. Excellent, ma'am.
Thank you
Excellent.
so much. Thanks to everyone.
Thank you so
Thank
much.
you.
Have a
Thank you,
good
everyone.
day.
Thank you.
Thank
Bye.
you. Thank you. Thank you so much.
Thanks, sir. Okay, ಅಲ್ಲ? Informative ಇತ್ತಲ್ಲ?
ಸರ್ ಇನ್ನು
Very good.
22 ದಿವಸ 22 ಪೀಪಲ್ ಇದ್ದಾರೆ ಸರ್, ಇನ್ನು ಲಾಗಿನ್ ಆಗಿದ್ದಾರೆ.
ಹಾ.
ಹೋಗ್ತಾ ಸರ್ ತುಂಬಾ ಚೆನ್ನಾಗಿತ್ತು. ಐ ರಿಯಲಿ ಲೈಕ್ ಆಲ್ ದ ಲೆಕ್ಚರ್ಸ್,
I
ಎಕ್ಸ್ಟ್ರೀಮ್ಲಿ ಗುಡ್.
You are
ಐ
a
ಥಿಂಕ್
pharmacologist
ಸರ್
anyway.
ಹಂಗಲ್ಲ ಸರ್, ಮೋಸ್ಟ್ಲಿ ತುಂಬಾ ಫಿಸಿಷಿಯನ್ಸ್ ನು ಕರಿಬೇಕಾಗಿತ್ತು. ಐ ವಾಸ್ ಟೆಲ್ಲಿಂಗ್ ಗಣೇಶನ್, ಐ ವಾಸ್
ಅದು
ಟೈಪಿಂಗ್.
ಏನಾಗಿದೆ?
I
Sir,
did
I think
send
the-
to our colleagues the heads of other things. I don't know what they did, but
Yeah.
unfortunately, I think today there is something happening on stroke.
ಸರ್ ಸೈಮಲ್ಟೇನಿಯಸ್ಲಿ ಸ್ಟ್ರೋಕ್ ಆಗ್ತಾ ಇದೆ. ಹೌದು.
There are a lot of things that are
EEG for psychiatrist. There's one more I had. So there's one more from Vivas happening.
That might
I think this unfortunate.
otherwise the session was extremely.
Sir, these are all your friends, sir? Vijay, sir, Dr. Vijay, sir?
No.
Your friends, sir? The speakers,
Through my another friend, I should have thanked him, Dr. Girish. I got to know a few of them. And Dr. Vahia is well known. Dr. Vahia is well known. I think you know him, Dr. Vahia.
But we can have another meeting where our physician doctors, they will really get benefited more, I think.
Sure. Okay. Thank you, ma'am. Thank you.
Thank you so much, sir. It was wonderful. Thank you, sir. Thank you.
Thank you.
Ganeshan, you have to, I think, stop
Yeah,
recording.
thank you. I'll end, yeah.